Hi, I'm Jack Cush, Executive Editor of RheumNow.com, and today is the 18th of March, and this is the weekend review for RheumNow.com. Some of the social feeds from this week included reports today, an interesting report regarding the risk of venous thromboembolism being higher in patients who have osteoarthritis and who take nonsteroidals. Number of different nonsteroidals studied, not all of them, not the coxibs, but nonetheless showed many of the common ones that we use, including diclofenac and ibuprofen and others, are associated with an increased risk of venous thromboembolism. Mechanistically, not said how this happens, and interestingly, not seen with naproxen. Also was an interesting report this week was a meta-analysis on leflunomide showing that it is not associated with interstitial lung disease or any other pulmonary complications, often alluded to, often in the Japanese literature. A 6-month study of patients who had chronic renal disease, especially CKD stage 3 and 4, they gave a cohort of patients either febuxostat at 40 milligrams a day or placebo, and showed the placebo patients had a steady decline in renal function, whereas those on febuxostat did not, further suggesting the potential safety of this drug in patients who have renal insufficiency. An interesting report, a retrospective report of rheumatic disease patients admitted to the ICU, showing that the most common ones were vasculitis, 36%, sarcoidosis, 14%, scleroderma, 10%, lupus, only 8%, and mainly for infection in 60% of the time. Overall, the number one reasons for hospitalization were either infection or organ failure. This was associated with an immediate short-term risk of death of nearly 20%. And long-term risk of death over a year or so of 50% in patients who do get admitted, so not a good sign. And lastly, the cost of biologics reviewed and showed that in 2011 through 13, the cheapest was Rituxan at $19,569, and other ones going steadily up, abatacept being next at $22,000, etanercept $25,000, certolizumab $26,000, golimumab $27,000 to $28,000, and adalimumab topping out at $30,000. Again, this is based on use, not based on any particular dose, and infliximab was not included. Some of the feature articles of this week, there were a number of interesting ones. You should look at the blog by Michelle Petrie and colleagues, which looked at the utility of hydroxychloroquine drug levels and sampling for blood levels in patients with lupus, showing that it does not correlate with disease activity, but does correlate with compliance and may therefore be a useful tool in that setting. Today we reported on a report from the journal JBMR from Seong Kim and others at the Brigham, who reviewed the use of bisphosphonates in patients following a hip fracture and correlated that with the FDA reports in 2005, 2007, and 2010. And after that time, they showed that these FDA reports giving warnings regarding fracture and atrial fibrillation, etc., was associated with the steady decline in the use of bisphosphonates. A bit of a problem, and we know that many of us are concerned about the use of bisphosphonates. An interesting report that appeared in Lancet today, a meta-analysis of many studies basically showing that while nonsteroidals are effective at improving pain and function in patients with osteoarthritis of the knee and hip, acetaminophen was not. In fact, while it may have been effective for a few parameters, overall acetaminophen not effective. This has been suggested by others. A very interesting report yesterday that appears on RheumNow.com was a report about sclerostin. As you know, sclerostin, patients who lack sclerostin have very hard bones, and inhibition of sclerostin has been a therapeutic angle for a new drug development in osteoporosis. Those trials are in progress and seem to be very promising. Nonetheless, researchers have examined the inhibition of sclerostin in animal models of rheumatoid arthritis, in both some that were TNF dependent and others that were TNF independent, and showed that if you inhibit sclerostin, you may in fact worsen rheumatoid arthritis in a subset of people, based on the animal data though, where there may either be no effect or there may be actually worsening of the arthritis with more pannus formation and more joint destruction. Many of us are concerned about the use of TNF inhibitors. Susan Goodman and others from the Hospital for Special Surgery did a nice review of the literature and showed that if you're on TNF inhibitors at the time of surgery, you are likely to have a higher risk of infection. This is not surprising, and many of us are concerned about this. Further studies are needed to look at the timing of when to stop that. My advice is you should stop for one dosing interval of the drug before surgery. The ACR is actually concerned about this and is developing a guideline about the perioperative use of drugs in patients with rheumatic diseases, and they are inviting comment up until next week, March the 24th. So go to the ACR website, rheumatology.org, go to guidelines, and put in your 2 cents about how to manage patients. And lastly, and maybe importantly, most importantly, were the CDC guidelines that appeared this week regarding the use of opioids in pain. In general, they reviewed when to initiate opioids, mainly in patients with chronic pain and the need for chronic pain medicine. While which opioid you should use, there are a number of different guidelines they recommend, including that you should start out with immediate use as opposed to extended release opioids. And lastly, to review the benefits, risks, and harms, and to monitor for that. That's it for this week. Tune in next week. We'll give you more news from Room Now. Goodbye.